What about the prognosis of heart failure in Indian patients? Is it different from the rest of the world, heart failure in the rest of the world? Well, friends, believe me, heart failure in India is much bigger challenge as compared to rest of the world. For example, the mean age of patients at the time of heart failure diagnosis is 73 in rest of the world, while in India it's around at the age of 53. So mean age is much lower in Indian patients as compared to rest of the world. In hospital mortality, once somebody is hospitalized, rest of the world mortality is just 3.8%, while in India the mortality approaches something like 25 to 30%. And post-discharge 6-month mortality, rest of the world is 8.6%, while in India it is 26.3%. So, heart failure pathophysiology in India is much more ominous. It occurs at a younger age, carries higher in-hospital mortality and higher post-discharge mortality. So this diagnosis needs to be taken all the more seriously in Indian patients. In inter-CHF study, heart failure survival rates were compared across different countries. India and Africa had the worst heart failure survival, whereas the South America, North America, even China had much lower mortality, and Indian patients were almost 2.5 times more likely to die as compared to rest of the world. And as I've already said, the heart failure prognosis mortality is much worse than the common cancers like bowel cancer, breast cancer, or a prostate cancer. In India, almost 8 to 10 million patients are suffering from heart failure. That amounts to almost 1% of the adult population prevalence. And post-admission or post-discharge mortality is something like 20 to 30%. The mean adherence to the guideline-directed medical therapy among the Indian patients is just 25 to 50%, and that occurs in a relatively younger age when the people are supposed to be more productive for themselves, for their family, and for the society. The incidence of diabetes in heart failure registry, Trivandrum heart failure registry, was 54.9%, and almost 40% of the heart failure patients were hypertensive. 5-year mortality and readmission rates in patients with heart failure in India are much higher. Trivandrum heart failure registry clearly showed that 3 out of 5 patients would die during 5-year follow-up, 60% mortality. The lack of guideline-directed medical therapy in heart failure with reduced ejection fraction and frequent readmission was associated with higher 5-year mortality. That underscores the importance of starting guideline-directed medical therapy in each and every patient who has been hospitalized with heart failure. Only 25% of patients who were discharged after the index hospitalization on GDMT, and importantly, prescription of GDMT and discharge was associated with a 5-year mortality rate. So that underscores that before discharge, guideline-directed medical therapy should be implemented in as many patients as possible if you want to mitigate the grave adverse consequences of heart failure hospitalization and its consequences. Interventions aimed at increasing the usage and adherence to guideline medical therapy is a very important step to improve the outcome in India. What are the goals of heart failure therapy? One is to increase survival. Second is to reduce the repeat hospitalization, and the patient should feel better. Quality of life should improve. You should reduce the mortality, premature death, ideally by reducing 2 main modes. There are 2 types of deaths in patients with heart failure. Number 1 is sudden cardiac death, which is based on arrhythmias, and another is mortality from progressive pump failure. Both can significantly come down by guideline-directed medical therapy. Trials have shown that ARNI reduces both sudden cardiac death as well as pump failure. So do beta blockers. So practically all GDMT would reduce both the modes of mortality in patients with heart failure. And earlier you start guideline directed medical therapy, more is the reduction in recurrent hospitalization. In fact, the first 30 days after discharge are the highest risk period during which rehospitalization occurs, and to reduce that, you need to reduce you need to increase the implementation of guideline directed medical therapy. As soon as patient has got some hemodynamic semblance for few hours, you can start the initial dose of guideline directed medical therapy, and by the time of discharge, patient should be on initial dose of all four guideline medical therapy if it is possible, and there should be a rapid escalation within a month's time. Majority of patients you should be able to achieve the highest tolerable dose of all four pillars of heart failure therapy. These all go a long way, not only in improving the survival but improving the quality of life.